Dear friends, dear guests, first of all, thank you for the possibility to present this lecture for the students. It's an interesting topic regarding melanoma and dysplastic nevi development after the additional intake of ranitidine, reumenidine, moxonidine, HCT, valsartan, rosuvastatin, and verapamil trandolapril. The potential role of nitroso contamination in medication is a possible substantial factor for the development of drug-related photocarcinogenicity. There are no competing interests, and this research did not receive any financial support. First of all, let me know to speak about several things about nitroso contamination and why this might be important for patients developing skin cancer. We know that the polycontamination with nitrosamines within the multi-medication in some patients could be seen as a serious factor for the current concept of skin cancers and melanoma pathogenesis in particular, in relation of terms like phototoxicity and photocarcinogenicity. Nitrosamines seems to be identified before decades to be photocarcinogens, independent of the fact if they could be carcinogenic or not. And this is because of the instability of the nitroso group under UV light. Some important papers from the past shed some light in this direction. Here we see a paper in toxicology and applied pharmacology about the testing of phototoxicity and hepatotoxicity of 22 nitrosamines, which was studied from the standpoint of evaluating their phototoxic and hepatotoxic properties. And the end result and conclusions of this paper is that with respect to differentiation between carcinogenic and non-carcinogenic nitrosamines, phototoxicity appears to be a non-specific effect related to the photodecomposition of their nitroso group. Photochemical decomposition of the nitrosamines and their instability under UV light has been known since 1964, and this has been published already from colleagues of us. Nowadays, we know that NDMA can be both formed and degraded through photochemical processes, and it can also exhibit phototoxicity, meaning its toxic effects can be influenced by light exposure. The same could be seen and published about NMOR or nitrosomorpholin. It is a nitrosamine that has been found to be phototoxic and genotoxic, and it can be formed as a byproduct in certain manufacturing processes such as rubber vulcanization, but has also been found as a contaminant in some drugs. When exposed to ultraviolet light, NMOR can become mutagenic and cause DNA damage, leading to potential health risks. The action spectrum of NMOR's phototoxicity follows its absorption curve, indicating that the light is directly involved in this toxic reaction. From that point of view, we can postulate that nitrosomorpholin is carcinogenic, mutagenic, and genotoxic, and there are several important papers. One of them is, of course, from Mochizuki, Nagasawa, Arimoto, Kobayashi about the genotoxicity and instability and nitrosomorpholin following UVI radiation, but there are also another papers in this aspect. One of the latest papers which is very important is about the photogenotoxicity of N-nitrosoprolin plus simultaneous UVA radiation in human-derived keratinocytes. It is again from a paper from Japanese colleagues, which has been published in Mutational Research Genotoxicology and Environmental Mutagenicity, 2025. Why this paper seems to be important? This is a very important paper because, first of all, it is showing that there is a possibility that UVA radiation could have a genotoxic effect on keratinocytes when applied with nitrosoprolin. In this study, it is important that the genotoxicity of nitrosoprolin has been studied using simultaneous UVA radiation without a metabolic activation in the liver. That means that prior the metabolic activation in the liver, there is a possibility that probably the deposition of nitrosoproline on skin and the subsequent UVA or UVB radiation could cause genetic mutations and release of nitric oxide. And the action spectrum of genotoxicity of nitric oxide, formation from NPRO plus UVA followed the absorption curve of NPRO, indicating that photoenergy was absorbed by the NPRO triggered photoreaction. So that we have a photo decomposition with mutagenicity regarding the keratinocytes. We know that the release of nitric oxide appears to be a key factor in the genesis of skin cancer because it could interact with reactive ROS, and then it is could be associated with melanoma and keratinocyte cancer pathogenesis. This is obviously a fundamentally different pathway of skin carcinogenesis compared to the metabolic activation of nitrosamines when metabolized and activated in the liver or intestines, for example, as well their subsequent carcinogenic effect. From that point of view, we could say that the simultaneous induction of mutations and the subsequent release of nitric oxide after photodecomposition is a possible good explanation for the potential link to keratinocyte cancer and, of course, melanoma development and progression in humans. However, we can say that when metabolized in the liver, nitrosamines could be also carcinogenic, and on that way we have a big carcinogenic substances in drugs. Nitric oxide and reactive oxygen species have a complex and often contradictory role in melanoma development and progression, but however, both of them have been implicated in its pathogenesis, in angiogenesis, immune evasion, metabolic dysfunction, and the main reason why we are performing this presentation is the concept of the drug-related nitrosogenesis concerning the skin cancer's pathogenesis as a whole and the melanoma in particular. All of the above suggest that the intake of some nitrosamines with medication occurs mainly in two ways: through the intake of ready-made exogenously produced nitrosamines, as it is the case, for example, with NDMA and valsartan, formed during synthesis of the drug outside the body, or there is also another possibility, the intake of medications containing secondary or tertiary amino groups, which in acidic environment, such as the stomach, for example, and in the presence of nitrate-rich food, are capable of generating photocarcinogens known as nitrosamines. In both cases, nitrosamines could be absorbed and deposited on the skin, where due to their instability of the nitroso group, they are subject to a photodecomposition with the release of nitric oxide, which with or without interaction with ROS is capable of acting as procarcinogen, including inducing mutations and skin cancer and melanoma, of course, in particular. It is for this reason that we have initiated analysis, retrospective and prospective in their nature, of data in patients with dysplastic Nevi and cutaneous melanomas to establish or rule out a pathogenetic association between the intake of potentially nitrosamine contaminated drugs, which are in the FDA list, or the intake of potentially nitrosamine not contaminated products, which are not listed in the FDA list for carcinogenic impurities, but seems to be phototoxic when they possess the secondary or tertiary amino group. And of course, the subsequent development of dysplastic Nevi and cutaneous melanoma. So that we have followed several drugs, and these drugs, some of them has been listed in the NDMA in the FDA list. Others are not. However, most of them possess secondary or tertiary amino groups. Of course, it remains an open dilemma which of the two types of intake plays the key role in generating skin cancer. Drugs that are general phototoxic that appear on the FDA list as carcinogen contaminated drugs, or substances that do not appear on the list, but they are described already in the literature as phototoxic, while also being described as possibly nitroso-contaminated, generating nitrosamines in the stomach. or both types probably of drug intake in the framework of polypharmacy act synergistically in direction skin cancer reduction. In all likelihood, very limited data are available on the general and phototoxicity of their metabolites also, which probably after metabolic activation could play some important role in direction carcinogenicity. Of course, the most important is to know that we have a pure carcinogenicity after liver metabolization, and we have the photonitroso carcinogenicity before the liver metabolization and after deposition on skin, based on cumulative phototoxicity and photocarcinogenicity due to the nitroso contamination, of course, subsequent photodecomposition under UV light, the nitric oxide release, and ROS interaction. We present 5 cases in this lecture where we are trying to analyze the thesis of drug-mediated nitrosogenesis, photonitroso carcinogenesis, or otherwise called oncopharmacogenesis, pharmaco-oncogenesis. The first paper, it's about a 52 years old patient, reports the presence of 2 nevi in the abdominal area that he noticed about 10 to 15 years ago. The reason for his visit to our clinic was that he has observed some changes in size and color and some bleeding in one of the lesions for at least 1 year. He reported arterial hypertension as comorbidities dating back to 2021 and started systemic therapy with amlodipine, moxonidine, hydrochlorothiazide. Additionally, from 1st for 2023, this therapy has been changed to valsartan, riomedine, and hydrochlorothiazide for 8 months to date. In the childhood, he has been treated also with ranitidine for gastritis and duodenal ulcer, and the dermatological status has showed an asymmetric lesion with some irregular borders about 3 of 1.2 centimeter in size, with irregular dark pigmentation and elevation on palpation in the area below the right mamilla. The lesion described was suggestive for cutaneous melanoma, and in the area under left mamilla, a lesion with a rounded shape and apparently clear borders about 0.5 centimeter in size, but also with irregular pigmentation has been noted, which was suggestive for dysplastic nevi. Of course, dermatosurgery is part of our job. An elliptical excision with a primary or operative surgical margin of no more from 0.3 centimeter in all direction has been performed on the lesion, which has been clinically and dermoscopically suspected for cutaneous melanoma, and elliptical excision with operative surgical margin of 0.2 centimeter was performed for the dysplastic nevi lesion. Histological verification showed superficial spreading melanoma for the first lesion, Clark 3, Bristol 0.79, and the lentiginous dysplastic nevus, clean resection lines. From that point of view, the melanoma re-excision is the rule, with a 1 centimeter field of surgical security on all directions, histologically verified and of clean resection margins. And CT of the head, chest, abdomen, and pelvis has shown no evidence for metastatic spread, and the staging was early melanoma T1A and 0 and 0. And the patient has been referred to the Regional Onco Cancer Center for follow-up. Here you see the first lesion suspected for melanoma, which has been surgically treated with a narrow surgical margin. After that, on the last image, you see the re-excision with 1 centimeter and before closure. And here is the other lesion, which has been also surgically treated. It was a lentiginous dysplastic nevi. We have, of course, a second case. It is about a 71-year-old female patient in severe general condition, which was admitted to the outpatient dermatology and dermatologic surgery clinic for cutaneous tumor in the symphysis area. There was also some unclear amnestic data of the pre-existence of melanocytic nevus at that region. She first noticed this dark protrusion about 2 years ago, 2021, which slowly grew to the size of a child's fist and bled spontaneously and was sensitive to touch. In parallel, during the last half year, she reported general weakness, loss of appetite, nausea and vomiting, pain along the course of the spine, and numbness of the upper lips. Of course, as comorbidities, she reported arterial hypertension dating back to 2018, for which she has been taking nebivolol hydrochlorothiazide once daily in combination with lercanidipine and hydrochloride twice daily for 5 years. Of course, here during the dermatological status, partially pedunculated tumor-like formation on the pubic area has been noticed with a size of 6 to about 3.5 or 4 centimeter, and a tendency of spontaneous bleeding with a smooth surface, but irregular pigmentation has been found. Here you see the dark pigmented lesion in this lady, so that of course, we have started with diagnostic histology, CT abdomen and pelvis was performed, and the process here was shown to be disseminated, to have disseminated in the lung, liver, and vertebrae. And we have planned, of course, to treat this giant melanoma formation with near surgical security marking, BRAF testing, and the initiation of probable targeted therapy, BRAF-MEK or pembrolizumab. However, it was a very severe case with metastatic spread, and we have faced those letalis in the subsequent days, so that that was unfortunately not possible. Case 3 is about another patient with a nevi, dysplastic nevi, clinically and dermoscopically localized on the foot. And first noticed about 10 years ago, but 24 years ago, this patient took nebivolol, fenopril, spironolactone, and rosuvastatin because of hypertension. And of course, we have taken the decision to remove it with a neurosurgical margin. It has been removed, and the histology has been shown that it was borderline lentiginous nevus. The case 4 is about a 61-year-old male patient which visited the dermatology and dermatologic surgery outpatient clinic for slow-growing formation of his left forearm that he first noticed 8 months ago. He reported also arterial hypertension. He started systemic therapy with perindopril amlodipine for 2 months. He then switched to verapamil trandulopril for 18 years, all of them phototoxic inducing drugs, as already known, or even before the time of the nitroso contamination has been known. And from the dermatological status, solitary pedunculated epidermal nodular formation has been noticed with a depressed surface and pale pink color. It was suggestive for fibroma. Of course, however, we have found additionally 3 nevi with a size between 0.7 to 1.1 centimeter with heterogeneous pigmentation, irregular shape, and indistinct markings suggestive for dysplastic nevi, which were observed in the dorsal region. And however, this we have performed, of course, 4 elliptical excisions under local anesthesia. The materials were sent for histological verification, which showed that the nodular formation in the right forearm histologically corresponded to a verruca with hyperkeratosis and 1 nevus with low-grade dysplasia and 2 additional nevi to dermal nevis with high-grade dysplasia. So that here you see the first, they are on 5P. You can see the 3 dysplastic nevi. And the other lesion which has been surgically removed. And then we have the case 5. It is a 63-year-old patient which came to our clinic because he has some problems again with some moles, and this mole was about nearly 30 years old, but some changes has appeared. He has also arterial hypertension, treated with bisoprolol once daily for 10 years, so that during the dermatological status. Multiple nevi were found on the patient's torso. There were several irregularly shaped nevi with indistinct borders and heterogeneous pigmentation, suggestive for dysplastic nevi. And of course, we have taken the possibility to remove all of them. Here you can see the different type of nevi, and there were 5 mixed melanocytic nevi with a marked degree of cytologic dysplasia, and 1 mixed melanocytic nevus with mild degree of architectural and cytologic atypia, and 1 seborrheic keratosis. Of course, here you can see the final result of these procedures. And why we want to present all this? Of course, purpose is to show that the clinical pathological correlations between the medication intake and the subsequent development of cutaneous melanoma on the melanoma precursor lesions. That also might be seen as a try to explain, is there a link between the drug intake, the generation of phototoxicity and photocarcinogenicity, especially regarding nitrosamines, or drugs which have tertiary or secondary amino groups, which tend to perform nitrosamines within the human body or external during the synthesis. And of course, that way we want to find the probable cause for the rising melanoma incidence, for example. The first case, we have the patient which has taken ranitidine, hydrochlorothiazide, amlodipine, moxonidine, and valsartan. All of them has been linked to nitroso contamination and possess secondary amino groups. And of course, in patient 1, the change of the melanocytic nevi to melanoma and dysplastic nevus occurred 1 year after the starting therapy with hydrochlorothiazide, amlodipine, moxonidine, and valsartan. And of course, newest data about hydrochlorothiazide has been known to be a human carcinogen since 2025 with respect to its phototoxicity in potentiation of keratinocytic cancer in YARC, published in Lancet Oncology. It has a low carcinogenic potency of 4 according to the FDA list, but similar data are also available for amlodipine, which is on the FDA list of potentially contaminated medications. It has also carcinogenic potency of 4, but it is after metabolization in the liver and not before the deposition on skin and the subsequent photodecomposition and the nitric oxide release. Moxonidine is not catalogued in the FDA list of nitroso-contaminated drugs with carcinogenic potency, but may be nitroso-contaminated and possibly also phototoxic. Ranitidine has been described also as nitroso-contaminated drug and associated with the development of several types of cancer. Its carcinogenic potency, according to the FDA list, ranges from 1 to 3, and tens of thousands of claims have been filed already to date regarding its carcinogenicity. Its nitroso contamination also suggests the possibility of photocarcinogenic activity after deposition on skin and subsequent photodecomposition and release of procarcinogenic mediators and substances. Valsartan is the same nitroso-contaminated drug, already exogenously tend to form nitrosamines, and has been linked to melanoma in different papers. Of course, here the attention to hydrochlorothiazide and the risk of keratinocyte carcinoma and melanoma. Here we know that increased risk of keratinocytic carcinoma and melanoma were observed with longer durations of the use of higher cumulative doses of HACTC. That means that photocarcinogenicity and toxicity could be linked to one structure of this drug, the secondary amine structure. Another paper about an antihypertensive drugs and skin cancer risk, a review of the literature meta-analysis about the calcium channel blockers in the cutaneous melanoma. And this is here also some data that family doctors and clinicians should inform their patients about the increased risk of skin cancer associated with the use of calcium channel blockers and beta blockers, and instruct them to perform periodic skin self-examination. This is also regarding the secondary or tertiary amino groups, which tend to perform nitrosamines, which seems to be photocarcinogens. calcium channel blockers in cutaneous melanoma, also published 2023 in the Journal of American Academy of Dermatology. We have a 32% increased risk to have melanoma when taking calcium channel blockers, and it is really disaster. Of course, we have published this presentation and moxonidine in this paper, but also in several other papers in combination with other possibly nitrosamine contaminated drugs, has been already linked to the cutaneous melanoma development and progression. And here, pericular high-risk BCC after additional parallel intake of torrazimid, moxonidine, and mirabegron, so that the patient one has already taken ranitidine. Ranitidine has been described in the scientific literature that it could cause phototoxic or photosensitive reactions, and NDMA is also already described as a contaminant in ranitidine, is known to be photolabile and phototoxic. And there are some papers already from 1995 that shows that ranitidine could cause probably UVA sensitivity and drug-induced photosensitivity. Several years later, 5 years later, there is also UVB-related photosensitivity. That means that UVA and UVB photosensitivity could be linked to the internal and external generation of photocarcinogens due to the structure of this drug. And we know that the decontamination of ranitidine with NDMA is photolabile, and this is about the ranitidine. However, the patient one took additionally valsartan, and there is a very strong evidence that valsartan contaminated with NDMA could be a really great problem. Even we have a different percent in the different countries in relation to melanoma development and progression. There is, however, the patients have a higher risk of developing melanoma with 10% and liver cancer at 12%. And this is something which is problematic, of course. The first case of valsartan-induced melanoma has been published by our team, and together me and Dr. Temelkova already. This is, I would say, 4 years before the French study. Our team has linked the melanoma to valsartan intake, and especially to the nitroso contamination. And about this case, the most important conclusions are based on the presented clinical pathological relations. It should be concluded that based on the intake of HCT, hydrochlorothiazide, and amlodipine, increased phototoxicity and carcinogenicity could occur, leading to favoring the development of cutaneous melanoma and dysplastic nevi. These data are fully consistent with many of the later appeared international scientific data on the subject. And the role of moxonidine as a phototoxic drug or factor could be followed up in the future clinical observation. The available nitroso contamination in the drug could be seen as a contributory factor regarding photocarcinogenicity. With this, we have concluded based on our own results, and when especially combined, for example, with nitrate-rich food. The role of NDMA and NDA in ranitidine and valsartan is interesting. Why it is interesting? Because it is also could be considered as a photocarcinogen, or since it is photolabile and phototoxic, there are no or limited data on the intake of nitrosamine contaminated ranitidine and the potential relation to melanoma development and progression. However, photodecomposition after UV exposure of this nitroso contaminated drugs or building drugs could be a good explanation for this scenario. The nitroso contamination in all these three drugs seems to be what might be associated with phototoxicity and carcinogenicity and subsequent melanoma development and progression. About case 2, we have, of course, again the focus of hydrochlorothiazide, and about hydrochlorothiazide we have already spoken in the first patient presented, but additionally we have nitroso-lercanidipine and nitroso-nebivolol. And we know that lercanidipine is a calcium channel blocker, which patients are taking for arterial hypertension, and it has also the potential to build nitrosamines, which are carcinogenic and photocarcinogenic substances. And while the tertiary amine in lercanidipine can be nitrosated, it is less reactive than secondary amines, but it is also it can be seen also as problematic. Lercanidipine and cutaneous melanoma, it could be seen as phototoxic then or due to its chemical structure, and can contain that way or build nitroso impurities, which could probably act as additional photocarcinogens. Photodecomposition after resorption with the nitrate-rich food and subsequent deposition might be also seen as possibility. And here we have also data from American colleagues, American journal published. It is patient 2, where we have lercanidipine and melanoma. And in these patients where they are speaking about the hydrochlorothiazide risk and the risk of melanoma and keratinocyte carcinoma, they have observed that there is a 32% risk of general during the intake of calcium channel blockers and melanoma, which we have already spoken about. And the patient 2 has taken nebivolol. Of course, there are controversial data and opinions in the world literature. Some data suggest that nitroso-contaminated beta blockers could trigger melanoma. Others could say that the generic substance might be responsible for the better clinical outcome in patients with advanced melanoma. And here, 2018, it's an interesting papers, antihypertensive drugs and skin cancer risk meta-analysis. Here we see that the beta blockers users were at increased risk of developing cutaneous melanoma with about 21%. And this is, of course, a problem. This might be the patients which has been taken nitroso-contaminated beta blockers, which could induce phototoxicity and photocarcinogenicity. Of course, case 2, we can conclude that data about hydrochlorothiazide are already available in the scientific literature, published in Lancet Oncology, and nitroso contamination in the preparation is also known, and it can probably be considered as partly responsible for the phototoxicity. Lercanidipine is phototoxic, and its chemical structure is thought to be responsible for this, or might be responsible for this. Nebivolol is also known for its phototoxicity, because long time before the nitroso contamination has been found in the world literature. Its secondary amino group is presented, it's available, and that means that nitrosamine generation is also possible. We believe that nitroso contamination is responsible for its procarcinogenic or phototoxic effect, leading to photodecomposition under UV light and subsequent development of photocarcinogenicity. All 3 drugs possess phototoxic activity, which could also be reported as procarcinogenic with respect to skin cancer and melanoma development progression. Nitrosamine formation is also or seems to be possible in all 3 drugs under acidic condition or external the human body. Case 3, again we have 2 well-known drugs, nebivolol, zofenopril, and rosuvastatin. Each of these medication is capable of forming nitrosamines in the stomach in the following conditions are presented: an acidic environment, a diet rich with nitrates, and the subsequent resorption of nitroso compounds could lead to the deposition of the skin before metabolic activation in the liver, and under the influence of ultraviolet light, the so-called photodecomposition and phototoxicity reaction could occur, which lead, of course, to the release of nitric oxide, ROS interaction, and the development of cutaneous melanomas. Antihypertensive drugs and skin cancer risk meta-analysis regarding nebivolol. There's also some interesting data. We know that beta blockers could be problematic for some cutaneous melanoma patients. Here our colleagues have also confirmed this observation after our findings about 21%. So that we believe that the nitroso contamination is responsible for this. Zofenopril, it's a very, very interesting drug. It's an ACE inhibitor. It is not in the FDA list for the nitroso contaminated products, but contains a tertiary amine group. That means it can form nitrosamines, of course, in acidic environments and in the presence of nitrate-rich food. and these are photocarcinogenic substances due to the possible subsequent UV-mediated photodecomposition and nitric oxide release. It has been associated in our own other literature data with the development of melanocytic and non-melanocytic skin cancers, precisely due to its phototoxicity and photocarcinogenicity. Here it is one of the oldest and most important studies which have motivated also me and my team to look in detail about the possible relations of drug intake and melanoma and non-melanoma skin cancer development. It is from my friend Beatrice Nardona paper, and here you see that the ACE inhibitors, especially for malignant melanoma, there is adjusted odds ratio about 1.71%, and unadjusted it is 2.42%. That means there is a very, very serious risk, 171% and 242% risk to develop malignant melanoma when taking ACE inhibitors. Probably we speak here about nitroso contamination of building in special population groups. However, when we look at the other percents of basal cell carcinomas and squamous cell carcinomas under the intake of ACE inhibitors, they have similar results. This was very, very interesting. We have another study from 2009, melanoma incidence and exposure to angiotensin converting enzyme inhibitors and angiotensin receptor blockers. And here we have this study is showing also something important, that the use of both classes does not seem to protect against the development of melanoma. So that the patient has taken already rosuvastatin, and rosuvastatin can be metabolized into phototoxic compounds. And we know rosuvastatin is particularly susceptible to photodegradation, forming various photoproducts or photosensitizer like the PP-RSV. This PP-RSV can absorb light and generate reactive oxygen species, potentially causing skin damage. Actually, it also exists in the form of nitrosorosuvastatin, suggesting that under acidic conditions and in the presence of nitrates, it may probably also form nitrosamines, which are photocarcinogenic. It is not cataloged in the FDA list, but due to its PP-RSV product, it is a problem because this product could generate ROS, and we know that ROS, together with the other drugs, which the polypharmacy, together with nitroso compounds, can double the photocarcinogenic effect of valsartan, hydrochlorothiazide, lercanidipine, and all other drugs. In this relation, this drug seems to be also problematic. Case 3, what we can conclude about our case. Data in the scientific literature about the phototoxicity and carcinogenicity of beta blockers, ACE inhibitors, and rosuvastatin are available. The cause of this phototoxicity, drug-related phototoxicity in general, in our case, is due or could be explained to various factors, some of which are not well understood, to some degradation products of the respective drug, like, for example, the rosuvastatin, the presence of secondary and tertiary amino groups with the ACE inhibitors and beta blockers, together with the nitrate-rich food, which could help, of course, of building endogenously nitrosamines, and the nitroso contamination outside the body has been already described additionally. The development of these external mediated photocarcinogenicities seems depends to great extent also on the or partially from the dietary habits of the patient. It is the nitroso contaminations that could be modulating and determining the incidence and photocarcinogenicity and the potentiation of carcinogenesis concerning skin cancer. The case 4, we have here two drugs additionally, amlodipine verapamil and perindopril trandopril. The link regarding the photocarcinogenicity and sensitivity of calcium channel blockers and the relation to cutaneous melanoma has been also analyzed in the previous cases. Endogenous nitrosamine formation seems to be possible, and photocarcinogenicity and sensitivity has been also reported. The link regarding the phototoxicity and photosensitivity of ACE inhibitor and the relation to cutaneous melanoma has been analyzed in the previous case. Nitroso contamination formation is possible. Case 5 is related to Nevi below. The link between beta blocker intake and melanoma is and remains controversial because we have to differentiate here between the generic substance and the tendency of forming nitrosamines and the tendency of combination with polypharmacy. Difference should be made between the action of the real substance, of course, and the endogenous nitrosamine formation. We have shown in case that some literature data suggests that the use of beta blockers might be related to 21% risk of melanoma development. It is related to photocarcinogenicity, but also to the existence of nitroso-Nevi below. This is our opinion. It contains a tertiary amine group in the stomach could be generate nitrosamines when taken together with nitrate-rich food. Of course, the subsequent cascade would be generated and mutations occur. What we can conclude at the end is that nitroso contamination of the drugs seems to be an unresolved problem at the current moment, and nitroso contamination might be linked pathogenetically to nitroso phototoxicity and nitroso photocarcinogenicity. The most drugs seems to be at least sporadically phototoxic based on previous data in the world literature before the nitroso impurity has been already discovered 2018. This photocarcinogenic problem is probably not based on the structure of the drugs alone, because if this was the case, we have to meet a daily photocarcinogenic problem, and that's not the case. We have a sporadic problem because of the possible sporadic contamination or synthesis or under acidic resorption, independence of the nitrate-rich food of the drugs, which have a specific structure, secondary and tertiary amino groups, and this is a complex disease, a very problematic case. Nitroso phototoxicity and carcinogenicity is dependent on many factors, like the intake of food additionally, the nitrate-rich food, especially the endogenously triggered nitrosogenesis. We have not to forget that we have also nitrosamine contaminated food, which could trigger phototoxicity and photocarcinogenicity as a probably completely independent factor. This is a new scientific horizon or door in that relation is open for current observations and research. From the name of the Bulgarian Society of Dermatologic Surgery, thank you for this possibility to share our vision. Best regards.